In relapsed refractory acute myeloid leukemia, there's really, again, a very poor standard of care. And unfortunately, although CAR-T has brought forth a paradigm shift in other blood cancers like lymphoma, myeloma, and acute lymphoblastic leukemia, we really do not have a CAR-T, to date that has really been looking that promising, although a number of trials that are undergoing. So this is the first presentation of the AMELI-01, which is an allogeneic off-the-shelf CAR targeting CD123. It's also been genetically modified for safety to not cause sort of graft-versus-host disease, given these are allogeneic cells, while at the same time has a knockout of CD52. This allows us to add a drug alemtuzumab to intensify the lymphodepletion, which is likely needed for allogeneic CARs in order to get the most robust expansion. So from a safety perspective, we enrolled 2 cohorts, one with just fludarabine cyclophosphamide and one with fludarabine cyclophosphamide and alemtuzumab. Across all the cohorts, it has overall been safe, but cytokine release syndrome definitely occurs. It actually occurred in 100% of patients, and unfortunately 2 patients did have grade 5 events. So we can have severe toxicity, although for the majority of patients was overall well tolerated. When we look at the expansion data, what we really learned in this trial was we have to do fludarabine cyclophosphamide alemtuzumab, because without that, we really get rapid lymphocyte recovery and very relatively poor expansion in patients that did not get alemtuzumab. Actually, about 10 times higher expansion in patients that got the 3-drug lymphodepletion. When we look at efficacy, we did see patient responses in both cohorts, but if we look at the cohort of patients that again got all 3 drugs, we did see 2 responses. One patient had a 60% down to 5% blast reduction and was taken off study to go to a donor lymphocyte infusion. And then really a remarkable patient that had failed multiple lines of therapy, had relapsed after transplant, had grade 4 cytopenias and a high blast burden. This patient was treated on study and actually achieved a complete remission by the end of cycle 1 and is actually in an MRD negative complete remission for over 1 year without the need for second transplant, as well as without donor lymphocyte infusion. Really one of the most marked responses, I would say, in the field of CAR-T for AML. So really going forward, I think to further improve safety, we're adding prophylactic tocilizumab to try to mitigate the severity of the cytokine release syndrome, as well as given this as an off-the-shelf product, it really allows us to do multi-dosing. So for the first time, we're going to sort of dose at day 0, but since we know that we have adequate lymphodepletion through the whole month, we'll give a second dose around that 2-week mark with really the goal to further augment efficacy. And again, this trial continues to accrue, and we look forward to putting more patients on it.